Alrighty now, thank goodness. I think this is going to be one of the last recordings that I actually make. We have finally reached the very end of the body. We started at the top of the body, worked our way through the arm, down through the trunk, the pelvis, the hip, and now we're going to hit the knee and the foot and be finished with that portion. A couple of things about the knee. It is the largest joint in the body. It also is one of the most prone to injury because there is so much stress and strain loaded through that particular joint. All the weight of the body continues to come on down towards the floor through the knees. All of the support that's provided in the knee is provided through muscles and combinations of ligaments. We're going to take a look at a bunch of that. It is a synovial hinge joint, so the only motion that we would see in the knee would be in one plane of movement, which would be flexion extension. There should not be hyperextension, and there should certainly be no AB and adduction. One other thing to note is that when we do stand straight up and down with our knees locked, we don't need muscles to stand for long periods of time in that position. And that's just kind of an interesting thing that when our knees lock, they help us to stand for very long periods of time without our muscles fatiguing. So the motions are flexion extension. Another component of motion in the knee is something called the screw home motion. It is a rotational type of motion that's going to involve three types of arthrokinematic motion. So if we do a closed chain activity of extension of the knee, so in other words, if we put the feet on the floor and come to a standing position, you'll see on page 324 that there are three components of arthrokinematic motion that are occurring. So the very first thing that happens is the femur is going to actually roll into a forward direction, and then as it rolls forward, it has to glide backwards posteriorly in order to slide into place. And then that very final little bit of motion is a rotation medially towards the inside, which is called screw home motion. So again, these rolling, gliding, and spinning, if you will, or rotating motions all occur within the knee. Now, when we do an open chain activity, same types of thing happen where the femur rolls forward and glides posteriorly, but instead of rotating medially, it rotates laterally. All right, so taking a look at the bones, we've got, just like we did on the femur, we have a medial condyle and a lateral condyle. We also have an area called the tibial plateau, which is this area where it sort of gets from a narrow portion on the tibia to a more proximal wide portion that articulates with the femur. And then on the front of the knee, we've already seen below the kneecap, we have the tibial tuberosity. If we look straight down on the top of the tibial plateau, we see an intercondylar eminence, which is a raised portion that sort of separates the two sides of the plateau. Now, if we look distally, we have, for the tibia, we have the part of your ankle that sticks out on the inside called the medial malleolus. For the fibula, at the proximal end, it doesn't actually articulate with the knee. The fibula is going to articulate with the tibia in two places. They're tib-fib joints, and they create a point of attachment for important muscles and structures. At the distal end is the lateral malleolus, and that's the thing that you hit on the coffee table a lot, or sometimes you hit on the inside too. So the patella we're already familiar with, and increases the moment arm of that quadricep muscle and is very important for producing strength of contraction. It also is protectant in that it covers the front side of the knee. Lots of ligaments to know, and these are important ligaments that you will need to know and understand. You've heard of the ACL and the PCL, the anterior cruciate ligament and the posterior cruciate ligament. Be reminded that the names come from the point of attachment on the tibia. So the anterior cruciate ligament is attached on the front side of the tibia, and the posterior cruciate ligament attaches on the back side of the tibia, which is what you're looking at from this point of view. You can see the posterior on the bottom. We have collateral ligaments. You'll recall from the fingers that collateral ligaments are ligaments that go down both sides, really to prevent or create stability to prevent essentially AB and adduction in the knee. So we have a medial collateral ligament and a lateral collateral ligament on the outside. We also have a medial and lateral meniscus, which is a cartilaginous disc that creates shock absorption. If we look down from the of the tibia, removing the femur, we can see this sort of figure eight arrangement. And one of the things that you might hear about is somebody having a meniscus tear. What tends to happen sometimes is it will separate from the plateau, from the tibial plateau, and it will sort of fold in underneath itself, in which case it will need to be sort of cleaned away and trimmed back so that it doesn't continue to pinch and create a lot of pain. There's the medial side and the lateral side. All right, so this area is called the popliteal space. This is an area where we've got muscles coming down from the more proximal end of the leg, crossing the knee and inserting just posterior or distal to the knee joint. We also have muscles, the gastroc, which comes up and attaches on either side of the femur, crossing the back of the knee. There's this sort of exposed space here, and what's important to know about that is there's quite a lot of nerve and blood supply in there. It's a very sort of vulnerable area. If you know anything about Greek mythology, that was where you shot an arrow at somebody during Greek mythology because it's a very vulnerable space. The pes anserine muscle group is a group of muscles that, if you look on page 332, that come down the knee on the medial side and connect with a common attachment. Pes anserine means goose foot or duck foot, so it's supposed to look a little something like a goose foot. It's where your sartorius and gracilis and your semitendinosus come together at a common attachment. They are going to help to produce some medial stability on the knee. Other things to know about, we've got mini bursa. We've got 13 in the knee joint, and as you'll recall, these are little pod-like sacs of synovial fluid that create little cushions against certain types of wear and tear in and around the joint. We're going to go over this in class. The patellofemoral angle, which is also known as the Q angle, which stands for quadriceps, is an angle that is measured between the attachment or the line of attachment between the pelvis and where the quadriceps muscle or the rectus femoris comes down and attaches over the attaches at the tibial tuberosity. That point of intersection with the patella is measured to create an angle. I'll show you how to do that in class, but 13 to 18 degrees of angle is typical. So we expect if people have less than that or more than that, that they potentially have some significant problems with their knees. Oh, there's the angle from the angle of the quadricep and the angle of the straight up and down line of pull. We'll go over that. That's the patellar tendon. That little angle. Okie doke. Muscles. So quadriceps, we have 4 muscles that cross the knee. The quadriceps, or I'm sorry, the rectus femoris, which we've already seen before with hip flexion. It crosses the knee and attaches distally on the other side. It is a 2-joint muscle. We also have the vastus lateralis. There's the quadriceps femoris, the vastus lateralis, the vastus medialis, and the vastus intermedialis, all on the front of the knee, which create knee extension. On the back of the knee, creating knee flexion, we've already seen these muscles because they create hip flexion. We have the semimembranosus, the semitendinosus, and the biceps femoris. 2-joint muscles, so they control the hip and the popliteus. The popliteus is a little muscle which has an interesting job. Its primary role is to unlock the knee out of that screw home motion that we had when we created that locked stance position by rolling and gliding and spinning the knee into place. So when we unlock the knee, we use the popliteus to initiate that. It's on the back side of the knee. Your gastroc then courses across the knee. It actually originates on the femur and inserts on the calcaneus. And it is a knee flexor, and we're going to see it again with ankle plantar flexion. The TFL that we've already seen before too runs down the lateral side of the femur, initiates at the pelvis. It's a two-joint muscle and attaches distal to the knee to create lateral stability for the knee, preventing any kind of AB or adduction, well, adduction specifically. Okay. We've got medial muscles on the inside, as I mentioned. These are part of the pes anserine muscle group, the gracilis and the sartorius, which come down and attach and provide us some medial stability. Gracilis and sartorius. All right, go on to the ankle and the foot. So as we go on further down to the distal end of the tibia is going to articulate. It's a weight-bearing bone, and at the distal end we have, as we already mentioned, the medial malleolus. The fibula is a primary attachment for muscles and other structures, and that creates the lateral malleolus. So your heel bone is your calcaneus, your largest tarsal bone, and then the second largest tarsal bone is the one that articulates with the tibia and fibula. So you can see that smaller one that's a little bit more anterior, or a little bit more superior to the calcaneus. Back to that again. Da, 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 da. The beginning of a triangle that's going to create a weight-bearing triangle between the base of the first metatarsal, the base of the fifth metatarsal, and the calcaneus. Again. All right, your phalanges, just like in the hands, we have phalanges. We have a great toe that has a proximal and distal, like your thumb, and then we have a proximal, middle, and distal with your four what are called lesser toes, the smaller toes, 2, 3, 4, and 5. All right, functional components of the foot. We have the hind foot, which is the talus and calcaneus. We have the midfoot, which is the navicular, cuneiforms, and cuboid, and the forefront foot, which consists of metatarsals and phalanges. And we will get into that much more when we start doing gait. So I might have another recorded PowerPoint, can't remember. All right, ankle motions. Now, the normal motions are plantar and dorsiflexion, inversion, and eversion. An abnormal motion is kind of considered to be AB and adduction. So when the toes are turned outward, like when you're pigeon-toed, that's called valgus, and when they're turned inward, it's called varus. And I'll give you some ideas about how to remember that in class. The foot joints, we have the MTP instead of MCP, metatarsal phalange. We have PIPs, DIPs, and at the great toe, we have IP. Also in the foot, we have ankle joint between the tibia and the talus. We also have a joint, subtalar joint between the talus and calcaneus. And then we have a transverse talar joint or mid-talar joint between the talus and the calcaneus, and where it articulates with the navicular and cuboid. We also have tib-fib joints, as I mentioned, where the tibia and fibula are going to attach superior and inferior. All right, so lots of ligaments. Quite a bit of stability is required in the ankle. It's the most frequently injured joint in the body. I don't think there's anybody who's never rolled their ankle. And ask Tyler Eifert, it is frequently injured. The lateral ligaments tend to stretch or tear. In his case, during the Bengals game last weekend, he actually tore the medial ligaments. There are the lateral ligaments. All right, arches. We have three arches. We have longitudinal arches. We have one that's medial, um, one that's lateral. Now the medial one is at the base of the great toe down to the heel. And so when somebody has lost that arch, we call that a fallen arch. The lateral is on the outside surface of the foot, and then we have a transverse, which goes from the base of the great toe to the base of the small toe. And that creates a weight-bearing triangle. Now that's real important when we're ambulating because that produces an opportunity for us to have balance, especially on uneven terrain. Muscles of the ankle for plantar flexion is the soleus and the gastroc. We already know about the gastroc because it also creates knee flexion. It was one of those two joint muscles. The soleus is just a plantar flexor. There's the gastroc, or soleus, and then the gastroc. For dorsiflexion, we use the tibialis anterior. For inversion, we use the tibialis posterior and the tibialis anterior together to pull the ankle out, kind of like when we had ulnar and radial deviation and used both sides of our front and back of our forearm. Posterior and anterior. For eversion, we use the peroneus longus and peroneus brevis. Peroneus longus, peroneus brevis. For flexion of the great toe, just like we had pollicis for the thumb, we have hallucis for the big great toe, flexor hallucis longus. And for flexion of the second, third, fourth, and fifth toes, we have the flexor digitorum longus. We don't have nearly as many muscles here because we don't have a lot of dexterity in our toes. All right, so those were perspective flexors that you could see. Extension of the great toe, we had the extensor hallucis, and extension of 2, 3, 4, and 5, we had extensor digitorum, just like we did in the hand. Hallucis, digitorum. Not sure how you can see those too well. We have the plantaris muscle. It is a weak ankle plantar flexor and also helps a little bit with knee flexion. Just good to know. We have intrinsics in the feet. Now, we do not have a lot of, we don't do a lot of fancy stuff with the muscles in our feet. So we don't have a lot of really refined motion, a lot of intricate action, and because of that, we do have intrinsics, but they're not nearly as well developed as in the hand.